3, 2, 1, go.
Welcome everyone to the CEC webinars of general cardiology, and we will today continue the program of valvular heart disease. We have today an important topic, which is the systolic murmurs between the guidelines and the real life. And I will be sharing the case regarding the mitral regurg, and my dear friend Dr. Muhammad Zahran will share with you some of the experience and recommendations of patients with aortic stenosis. So we have a 60-year-old female smoker. Body mass index is 21 kilogram per meter square. She's not diabetic or hypertensive. Actually, her baseline blood pressure is 90/60, and she's complaining of chest pain. She had an ECG denoting an extensive anterior myocardial infarction with ST segment elevation also in 1 and AVL. So what to do for this patient? Should we order troponin? Should we do a thrombolytic therapy? Or should we rush this patient to primary PCI? We have a patient that is more or less stable with acute anterior myocardial infarction, old age and smoker, so with an established diagnosis of acute myocardial infarction. So what's the proper management? The presentation was 4-hour duration between the onset of pain and the presentation to the hospital. Upon arrival, the patient arrested, and she was successfully resuscitated after 6 minutes of cardiac arrest. So I think there is no room for question here. This patient should undergo primary PCI. The patient was mechanically ventilated with intravenous vasopressors to elevate her blood pressure to 90/70. She received dual antiplatelet therapy in the form of aspirin and ticagrelor, and we choose the right femoral axis. This was the shadow of her right coronary artery, and this is the left coronary artery. We have a total LAD, and we have severe lesion in the circumflex OM. So an attempt was done to recannulate and revascularize the LAD, which was successful, using an XB guiding catheter, a BMW wire, and 2.0 by 20 millimeter balloon. And 2 drug-eluting stents were implanted into the LAD, regaining the flow to the LAD with minimal compromisation of the diagonal branch. The right coronary was successfully cannulated, denoting that there is no evidence of severe lesion in the right coronary. So we decided to move on, as the patient was borderline. She was the blood pressure was 90/70, only using vasopressors, so to complete the revascularization and to revascularize the circumflex. This was the final result. The patient was weaned from the mechanical ventilation. Intravenous vasopressor was gradually weaned. Blood pressure went up to 100/60. However, echocardiography post-PCI showed mildly dilated left ventricular dimension with severe impairment of contractility. Ejection fraction was 20%, mildly dilated left atrium, and severe mitral regurg. We all know that mitral regurg is divided into primary mitral regurg and secondary mitral regurg. In primary mitral regurg, either it's a problem into the leaflet structure itself by leaflet perforation, mitral valve prolapse, and progression of the mitral valve prolapse, or rheumatic valve disease, mitral anal calcification, or drug-induced mitral regurg. But in the secondary mitral regurg, it's either dilation of the cavity or ischemic cardiomyopathy or dysfunction of the papillary muscle that causes the acute mitral regurg and progress to chronic secondary mitral regurg. So in the secondary mitral regurg, it's always associated with annular dilation or not? Kindly respond. Is it true that every secondary mitral regurg is associated with an annular dilation or not? What do you think, Zahran?
So we're getting most of the answers for false, Dr. Hayes.
Okay. And this is right. This is the right answer. It's not necessary to have annular dilation to have a secondary mitral regurg. If this is an acute event, if this is an acute papillary dysfunction, or this is an acute ischemia, the cavity of the left ventricle and the annulus will not have a time to dilate. With the mitral regurg, there will be almost normal dimension as here in our patient. So this mitral regurg is caused by severe ischemia, severe extended ischemia, and this is the cause of the mitral regurg with almost normal dimensions. So this is a very tough decision ahead. We have mitral regurg that should be assessed in a patient with deteriorated left ventricular functions, and she just had 3 implanted stents. So the next question is, how can we depend on the regurgent jet area for assessment of severe or the severity of mitral regurg? True or false? Kindly respond.
Most of the answers are going towards false, Dr. Hayes.
So we have a very skillful audience today. You're lucky. The only benefit from the regurgitant jet is to diagnose mitral regurg in severe mitral regurg, but the quantification is not accurate with mitral regurg jet area. So we have to apply other parameters to better quantify this mitral regurg. So how we answer this question, how severe is the mitral regurg? The European Society have given us some steps and some clues to diagnose whether this mitral regurg is severe or not. One of them is mitral valve morphology, the presence of the color flow jet, the continuous wave signal and regurgitant jet dense or triangular, and if there is large flow convergence zone. If we go further, we will seek the vena contracta width, the upstream vein flow, the inflow AOF dominancy, and the time velocity interval of the mitral valve ratio to the time velocity interval of the aortic valve. If the vena contracta is more than 7 millimeter, this is a severe mitral regurg. If there is an upstream systolic pulmonary vein flow reversal, this is a severe mitral regurg. If there is an EOF dominant more than 1.5, this is severe mitral regurg. And if the ratio of time velocity interval mitral to aorta is more than 1.4, this is a severe mitral regurg. As we go further into evaluation of the mitral valve, if the OA is more than 20 millimeters square in the secondary mitral regurg, this is a severe mitral regurg. Regurgitant volume is more than 30 milliliter per beat. This is a severe mitral regurg. And of course, as we mentioned before, the difference between the primary and secondary mitral regurg is that in primary mitral regurg, we take into consideration the presence of left ventricle and left atrial dilation, because this is a progressive, slow disease. But in the secondary mitral regurg, we do not take them into consideration because we can have a severe mitral regurg, secondary mitral regurg, without left ventricle or left atrial dilation. In the American Society, they depend upon the regurgitant area, the regurgitant volume, and the regurgitant fraction to assess the severity of the secondary mitral regurg. So what's the vena contracta? The vena contracta is the convergence at the mitral valve orifice towards the left ventricle, which is, and this is, I'm terribly sorry, I have, and this is the pisa, which is the diameter of the half circle at the mitral valve orifice or the regurgitant orifice towards the left ventricle. So in order to assess the pisa correctly, we must take into consideration the adjustment of the aliasing velocity, because if we have a high aliasing velocity, we will not detect the pisa. In this patient, we have an aliasing velocity set of 67. We do not see the pisa correctly, but when we adjust it to 33, we could assess the severity of the mitral regurg properly. Another thing is the E velocity and time velocity integral, which goes hand in hand with each other with the severity of the mitral regurg. The more the E wave, the more, and the length of the time velocity integral, the more severe is the mitral regurg. Other thing is the pulmonary venous Doppler flow. The more we have a prominent D and the reversible of the SD ratio, the more we have severe mitral regurg. So to complete our study, we must detect and calculate the left ventricular size, left ventricular volume, ejection fraction, left atrial size, and pulmonary artery systolic pressure. In the condition that we have more than mild mitral regurg, as we mentioned, coronary flow Doppler is not adequate. The quantitative methods are needed, the PISA and the VC. Left ventricle, left atrium, and pulmonary artery systolic pressure are essential parameters for completeness of the mitral regurg assessment, because they will contribute into the decision whether to do an intervention to this mitral valve or to complete into medical treatment. So in our patient, the vena contracta was 0.7 centimeter. The effective regurgitant orifice was 0.3 centimeters square. The RV was, the regurgitant volume was 50 milliliter. The regurgitant area was 9 centimeters square. There was systolic slow flow reversal into the pulmonary veins. The pulmonary artery systolic pressure was elevated, was 50 millimeter mercury. Left atrium was 4 centimeters, and the left ventricular dimensions, the diastole was 6, the systole was 4.7, and the ejection fraction was 20%. So we have, by all parameters, a dilated ventricle, a failing ventricle, and severe secondary mitral regurg. And we all know that the association of severe functional mitral regurg with any condition, whether it was ischemia, heart failure, or ischemic cardiomyopathy, will increase the mortality and increase the percentage of survival of these patients dramatically, comparing with patients that have normal mitral valve or mild to moderate mitral regurg, which is very important. The 10-year survival of these patients is less than 30%. So what we do next? Send this patient immediately to mitral valve surgery, or try medical treatment and close follow-up of clinical status and reassess the echocardiography. Can anyone tell us what to do?
So some people are voting for medical treatment and close follow-up.
Okay, perfect. This trial compared the pre-PCI, early post-PCI, and late post-PCI, moderate, mild, severe mitral regurg, and the switch between both did show us that post-primary PCI, moderate to severe mitral regurg, 19% of patients had moderate to severe mitral regurg after the primary PCI. And the predictors is the long ischemic time and, unfortunately, the female gender. And the regression in the long-term follow-up is only 18%. And this is associated with poor outcome, as we mentioned before. More, these patients do not respond adequately to guidelines mediated medical treatment, and they do not tolerate the doses or the adequate doses of medication in 50% of them. So these are tough patients that do not have long survival, and they do not have an adequate chance to tolerate medical treatment in order to get better. And when we studied the switch from a non-severe to non-severe mitral regurg, which is the best and the comparative group, and patient who had non-severe mitral regurg that turned to be severe after PCI, this group had the worst outcome a long time. So any mitral regurg that turned out to be severe, they will shift from the better outcome and better prognosis group to the high mortality group, unfortunately. This is the ECG of the patient after the PCI. So would you consider CRT or for this patient or not? And the other question to the audience, do the presence of mitral regurg will affect mitral regurg and heart failure, will affect your decision in choosing CRT to this patient or not? Kindly vote. Are we following? Zahran?
We suddenly lost the voice, and then the voice came back again.
Okay, I was asking about whether the presence of severe mitral regurg will affect the decision of doing this patient a CRT or not. Is the presence of mitral regurg will contribute in your decision to implant a CRT for this patient or not? And if by all means this patient will need a CRT or not?
CRT-D or CRT-P?
Whatever, as you like.
Because we have votes for ICD or CRT-D.
So this patient, does she meet the criteria of implanting an ICD?
The post-MI patient, ejection fraction less than 40% or not.
Yeah, she definitely have all the criteria for an ICD, but does she has a criteria for CRT?
So we put the QRS complex in the portfolio of the QRS complex. So there is left bundle, no.
There is no left bundle.
I think this is an indication for an ICD, not a CRT.
Yes. And this is the trick. The presence of mitral regurg is not one of the indication of implanting a CRT or an ICD. The CRT and RCD have solid criteria that presence of mitral regurg or severe mitral regurg do not contribute in one of them. And this is the message. So the decision was to give time to the ventricle to recover. We put the patient on dual antiplatelet therapy, statin, valsartan, bisoprolol, torsemide, and spironolactone. 5 months later, she still have symptoms of heart failure, function class 3, with total exercise intolerance. Ejection fraction improved to 45%. However, the severe mitral regurg persisted. So now what to do? Is it time to decide the mitral valve surgery or to continue on medical treatment, considering that the patient's ejection fraction is improving? So what's your opinion? What to do? Do you hear me? Zahran, do you hear me?
Yes, Haitham, your voice is clear. Yes,
Thank
please
you.
continue.
So I'm waiting for the answer of the question. Is it time to refer this patient for surgery, or we can continue on medical treatment with the hypothesis that the ventricle ejection fraction is improving, and we could benefit more from the medical treatment regarding that the left ventricular functions is improving from 20% to 45%. So what's the suggestions?
So, Isam, the key answer here is the symptoms. This patient is symptomatic with functional mitral regurgitation secondary to the myocardial infarction and the ischemic heart disease. We tried the best medical treatment up to sacubitril valsartan in these patients. However, she is still severely symptomatic despite this medication. So I think the best management here is to move to intervention to this mitral valve taken into consideration, and this intervention according to the guideline is for symptomatic improvement mainly, we have some data regarding the mitral valve, the percutaneous mitral valve repair for that it was associated with improved prognosis and reduction of the mortality.
Yeah, it's coming up with the year. It's
Yeah,
coming up.
but till now in the guidelines, the mitral valve surgery, the aim of mitral valve surgery is symptomatic improvement.
Yes, to improve the symptoms. The trick of this question, dear Dr. Karim, is that the improvement of the left ventricular function is not countable. This is a virtual improvement or false improvement. At the presence of severe mitral regurg, this ejection fraction is far overestimated. And as you mentioned, the presence of symptoms is the key for the derive of our decision. So this patient will undergo surgery to treat the mitral regurg and to improve the symptoms, as you mentioned elegantly. Either because this patient have another indication for CABG, like revascularization, or this patient failed medical treatment with an ejection fraction more than 30%, or this patient had an ejection fraction less than 30% with an option for revascularization. So the symptoms are the main drive of our decision here. So as you mentioned, is there a role for mitral valve repair percutaneously in this patient or not? The trial showed that the group of patients with device closure had less events and more survival. However, this is not stated in the guidelines. The aim is to reduce the symptoms till now until other more wealth data appear into the edge-to-edge percutaneous procedure, which is the mitral clip. We only consider this type of management either for patients that have severe surgical risk who cannot do surgery, or an alternative to medical treatment if we decided to do medical treatment CRT. So the mitral clip or the percutaneous edge-to-edge procedure is also used till now into the guidelines to reduce the symptoms and not to improve survival. So in this patient, would you choose a mechanical or bioprosthesis? This is an easy question. I think regarding this patient, we have an old patient that receive dual antiplatelet therapy and will continue after surgery at least on one antiplatelet therapy. She has a high bleeding risk. So the choice here is for bioprosthesis and not for mechanical prosthesis, which is stated also into the guidelines as class 2A recommendation. So the final decision was to do a mitral valve surgery. We did a perioperative coronary angiography that showed patent stents with LAD and circumflex. The patient's symptoms markedly improved after mitral replacement with a bioprosthesis. And for summary, this is a female patient with an anterior MI that had a post-cardiac arrest. She had primary PCI to LAD and circumflex, complicated with severe mitral regurg. We tried symptomatic medical treatment first that did not get benefit, so we jumped into mitral valve surgery as recommended by the guidelines. And thank you so much.
Thank you so much, Dr. Haytham, for this wonderful presentation. about the case of secondary mitral regurgitation, which actually you showed elegantly how you managed the full portfolio of such a case, starting from the revascularization procedure for the primary PCI and ending up to the final destination of performing a mitral valve replacement by a tissue valve. So I think we will move directly to the second half of this webinar. We'll be discussing severe aortic valve stenosis, the guidelines and the scenarios presented in the guidelines about how to do. This is not involving the very procedural imaging for the TAVI procedure, because this is the next webinar. We'll have a very interesting webinar next Thursday that will be discussing the very procedural imaging and the TAVI procedure in full detail. So this is just a glimpse from the guidelines about the different scenarios. So let's start by this common scenario for a 67 years old man with a history of hyperlipidemia on hypertension, who is evaluated in the ER after a syncopal event. The gentleman stated that he had another 2 episodes of syncopal events over the past 3 months, and he has developed occasional exertional chest pains over the past 1 year. His medications include lisinopril for hypertension and atorvastatin for hyperlipidemia. On examination, his blood pressure was 146/87, heart rate 102 with irregular pulse, with normal respirations at 14 breaths per minute. His cardiac auscultation showed a 3/6 late systolic murmur, mostly audible at the right upper sternal border, and obscured the second heart sound with irradiation to the carotid artery. His carotid pulse was blunted. The upstroke was delayed compared to his heart sounds on auscultation. They performed an ECG in the ER that showed LVH, and the bedside troponin was negative. So, from this clinical scenario, we would perform an echocardiography as the next step to determine what we are thinking about this murmur, and we got a calcific aortic valve by echocardiography. So what is the next step? And here we move to the ECC 2017 guidelines for managing patients with valvular heart diseases. And it states that if you have a valve morphology by echocardiography that makes you suspect that the patient has aortic stenosis, like this one, then the next step would be assessing the velocity and the gradient across the aortic valve. As you move to the right-hand side of the slide, if you get a high gradient aortic stenosis, defined as a mean pressure gradient more than 40 millimeters mercury or peak velocity more than 4 meters per second, which is equivalent to a peak pressure gradient of more than 64 millimeters mercury, then this is a high gradient aortic stenosis, and this is a very easy scenario. You don't have a high flow status, you don't have hyperthyroidism, you don't have anemia, you don't have arteriovenous malformation, yes. So this is a severe high gradient aortic stenosis. You need to manage this severe aortic stenosis. This is a very easy situation. But what if the patient does not have a peak gradient that's more than 40? What if the mean gradient of this patient is less than 40 millimeter mercury and his velocity is less than 4 meters per second? The second step would be assessing the aortic valve area. And why do you need to assess the aortic valve area? You need to assess the aortic valve area because in some cases, actually, although the gradient is less than 40, so by definition of the pressure gradient, this is not severe aortic stenosis, but still This is a significant aortic stenosis for this patient. And this is because there is a profile of patients which have, let's say, an impaired function of their left ventricle. And this impaired function of the left ventricle does not generate a significant gradient across the aortic valve. Or the patient has a small size left ventricle, and this small size left ventricle does not allow the ventricle to fill properly and to eject an adequate stroke volume across this valve. So here we need to perform additional measurements. The first one of them is assessing the aortic valve area by the continuity equation, which is very easy. The pressure multiplied by velocity across the LVOT equal the pressure multiplied by the velocity by area of the LVOT equal the velocity by area across the aortic valve, and you can calculate them all by echocardiography, and by crisscrossing you can calculate the aortic valve area. So if you calculate the aortic valve area and it's bigger than 1 centimeter squared, then this is not a severe aortic stenosis. This is a moderate aortic stenosis, and the situation is solved at step. But if you get an area that's less than 1, but still the pressure is less than 40, there is something actually maybe have happened. Maybe you have a measurement error that has caused an underestimation of the gradient or the flow or the aortic valve area. So here you need to define the flow status, which is the stroke volume index of the patient. Of course, you can calculate the stroke volume index by minus n diastolic volume minus n systolic volume. This is the stroke volume, and the stroke volume divided by the index per meter square surface area is the stroke volume index. So if the stroke volume index is normal, so you have a normal flow across the aortic valve, 35 milliliter per meter square stroke volume index or more, then this is not a case of severe aortic. But if you have a low flow, then here you have one of the two options that I told you. The flow is not significant across the aortic valve, and so it does not generate the pressure across the aortic valve. I mean, you have a normal ejection fraction, but the flow is still less, then you need to have an integrated approach. This integrated approach will include the calcium score by the C. But if you have an LV ejection fraction that is less than 50%, then in this case you will need to perform a do-glutamin echo. And the do-glutamin echo aims at what? Aims at calculating the contractile reserve. If you have a proper contractile reserve, this means that the ejection fraction increased by 20% or more, then yes, and the pressure gradient is improving, then yes, this case is a severe aortic stenosis. And here you actually have a case of severe aortic stenosis. I just need 30 seconds because I think the YouTube connection stopped. I will continue live streaming. It's working. Maybe Ahmed Saeed or someone of
So,
our
Doctor,
colleagues can follow up on YouTube. The YouTube is working properly or not?
thank you, Dr. Zahran, for this good introduction of the algorithm for diagnosing the severe aortic stenosis with the echo. So I just only have one question. If do we need to measure the blood pressure before starting taking all these measurements? So I can say it is the pressure gradient
Very,
is.
very important one. Of course, yes. You need to measure the systolic and diastolic blood pressure, and you need to have an adequate heart rate also around 80, because all of your measurements, especially the flow measurements, are all of them affected by uh, the and affected by the heart rate and affected by the volemic status of the patient. If the patient is hypervolemic or hypovolemic also, you will get the same problem. So this is why we said that the high flow cases also should be kept upon, like those anemia, hyperthyroidism, and AV shunts. And number two, as Dr. Ahmed Saeed said, you need to measure the blood pressure and you need to have an adequate or controlled heart rate when you are performing your measurements. So I will go back again to this slide. I defined the flow status of my patient. If the patient has a normal stroke volume index, then a severe aortic stenosis, as I said, is very unlikely. If he has a low flow across flow across a stenosed valve, but the question is the pressure gradient is below 40. So I need to assess the LV ejection fraction. And as I said, the LV ejection fraction is low, below 50%. We do the total echo, and we have a positive flow reserve, or we have no flow reserve. Accordingly, if the ejection fraction is normal above 50%, I will go to the calcium score by CT, and I will show you next how we do this in health to calculate the severity of the aortic index. So this is the criteria that increase the likelihood of severe aortic stenosis in patients with aortic valve area that is less than 1 centimeter, but the mean gradient is below 40 millimeter, and the patient has a preserved ejection fraction. So what is the clinical criteria? Usually, typical symptoms without other explanation, elderly patients that have a small left ventricular cavity and have a stiff left ventricle, qualitative imaging data, LVH, additional history of hypertension, reduced LV longitudinal function without another explanation. The mean gradient is a number between 30 but less than 40, or you have an aortic valve area that's less than 0.8 centimeters square. And you get a low flow stroke volume index less than 35 milliliter per meter square, confirmed by techniques other than Doppler, including cardiac MRI or multi-site CT or TB echo. And next is the calcium score. So if you have a calcium score for a gentleman that is more than 3,000, or for a lady that's more than 1,600, then severe aortic stenosis would be very likely. It would be likely if the guy has a score more than 2,000 or the lady has more than 1,200, and it is unlikely if the guy has a score less than 1,600 or the lady has a score less than 800. So this is the part where we integrate the multi-slice CT, and this is new in this version of the guidelines. So this is the whole slide for the whole pathway. You got a patient, you clinically suspect him to have aortic stenosis. You did an echo, you saw the valve morphology suggestive of aortic stenosis. The first step is assessing the gradient across the valve. If the gradient is higher than 40 millimeter mercury, the situation is very easy. This is a severe high gradient aortic stenosis. Proceed to the management. Okay, what if the pressure is less than 40 millimeter mercury and you assess the aortic valve area and you found it to be less than 1? The aortic valve area is more than 1, this is moderate aortic stenosis, this is outside of the lecture. But if the aortic valve area is less than 1, as we said here, you need to define the stroke volume index. And if the stroke volume index is normal, this is not severe aortic stenosis. If the stroke volume index is actually low, you assess your ejection fraction. If it is less than 50%, you do the contractile reserve. If it is more than 50%, you go to the calcium score by multi-slice. And this will move us to the next step. When would you intervene and how would you intervene? So for symptomatic aortic stenosis, of course, severe high gradient stenosis with a mean gradient more than 40 or peak velocity more than 4 meters per second. Intervention is also indicated in symptomatic with severe low flow, low gradient, which is less than 40, with reduced ejection fraction, but those having a positive flow or contractile reserve, excluding pseudo-severe aortic stenosis, because if you made the contractile reserve and the aortic valve area increased to be more than one and the pressure gradient was falling down, then this is a pseudo aortic stenosis, pseudo severe. This is not a severe aortic stenosis. Finally, intervention should be considered in symptomatic patients with low flow, low gradient aortic stenosis with normal ejection fraction, but you need to carefully confirm the severity of the aortic stenosis. And in this case, you will need to use the CT calcium score, the 3000, the 2000, and the 1600 scores, as we said previously. And of course, whenever you're going to perform an intervention, you should not perform an intervention with severe comorbidities or if the intervention is unlikely to improve the quality of life. The second question would be how to choose whether by surgery or whether by transcatheter valve replacement. So aortic valve intervention, of course, should be performed as what we said previously in the heart valve center, where you have a heart team including an interventionist and a surgeon. And the choice is individualized according to the technical suitability and the weighing of the risk and benefits of each modality, and in addition, the local expertise and the outcome of this particular center. Some centers have very good surgeons, some centers have very good interventionalists. So this will modify the choice in a center by center basis. Actually, surgical aortic valve replacement or SAVR is recommended in patients with the low surgical risk, having an STS or Euro score 2 less than 4%, or logistic Euro score 1 less than 10%. They should not have, of course, frailty, porcelain aorta, or post-chest radiation therapy. And of course, TAVR is recommended in the patients where SAVR would not be performed as assessed by the heart team. In the patient who are increased at surgical risk, as we said, those the option for the TAVR should be made by the heart team, and the TAVR would be favored in the elderly patients suitable for the transfemoral access. So this is very important also. There is a role for the balloon aortic valvuloplasty as a bridge to SAVR or a bridge to TAVR if the patient is hemodynamically unstable, or in the patient with severe aortic stenosis who requires an urgent major non-cardiac surgery, example something like a strangulated hernia, something like a perforated ulcer, whatever, and he needs to perform an emergency 10-minute procedure before he is fit to perform the surgery. Of course, the balloon aortic valvotomy can be considered as a diagnostic means with severe aortic stenosis and other cause of symptoms. The patient has severe chest disease, restrictive lung disease, he cannot breathe very well, he cannot perform physical activity. At the same time, he has a severe aortic stenosis and the patient has know how you're gonna manage this situation, then in this case you can perform the balloon as a start to see how it's gonna work upon, and then after that you will decide whether to do the surgery or the TAVI. And take care that in asymptomatic patients with severe aortic stenosis, but they are eligible for surgery, if the ejection fraction falls below 50%, not due to another expected cause, then aortic valve replacement is indication. And in asymptomatic patients with severe aortic stenosis and abnormal exercise, testing that shows symptoms on exercise related to aortic stenosis, especially with fall in the blood pressure, hypotension with exercise, and it can be considered in any of the following conditions: very severe aortic stenosis as Vmax more than 5.5, rapid progression of the aortic stenosis by a Vmax progression more than 0.3 meter per second per year, markedly elevated beta natriuretic peptide levels more than threefold age and sex corrected normal range without any other possible explanation, and severe pulmonary hypertension where the systolic pulmonary artery pressure at rest more than 60 millimeter mercury, better to be performed by invasive measurements without any other explanation. Of course, if you're going to perform another surgery on the aorta itself or on another valve, and if it is moderate aortic stenosis undergoing a cabbage or another surgery within the aorta or another valve also, you can perform the surgical aortic valve replacement. So to summarize the management of the severe aortic stenosis, the first step, symptomatic or not. If it is symptomatic, yes, you will proceed and you will choose between TAVI and surgery as we said previously. The patient is asymptomatic, you will look at the ejection fraction. If it dropped below 50%, then you will proceed with the surgery. If it's not below 50%, then you can perform the exercise test if the patient is physically active. And if the exercise test is positive, you will perform the surgery. Otherwise, you will search for the other manifestations as the pulmonary hypertension and the rate of progression and so on. And otherwise, you will do a re-evaluation every 6 months for the symptoms to occur. I finished my presentation here. I will be back to Dr. Ahmed Saeed if you would like to ask any moderated questions.
Dr. Zaran, thank you for your elegant presentation. Is there a rule for hemodynamic assessment, invasive hemodynamic assessment of aortic stenosis? If
Yes,
data are controversy regarding the echo and the
yes.
clinical status?
The peak-to-peak measurement in the cath lab across the aortic valve, it is the most correlated with the mean pressure gradient measured by echo. So you pass two catheters, one in the left ventricle and one in the aorta, and you calculate the peak-to-peak gradient. And usually this peak-to-peak gradient correlates very well with the severity represented by the echocardiogram.
Dear Zahran, I have a question, which is, I think, the question that is now rolling to all of us is the role of TAVI is now emerging from the high risk patient to the moderate risk patient, and now the ongoing trials and the preliminary results of these trials encourage the use of TAVI in patient moderate to low risk. So, what's your opinion or perspective about the emerging of TAVI or invasive or catheter-based invasive treatment in severe aortic stenosis?
So actually what you are saying is very valid. We have here now the TAVR has been performed first on the patients that who were deemed not to be fit for surgery, and then they moved upon to the high risk patient, and then they moved to the moderate risk patient, and now they moved to the low risk patient. So actually, this was the natural progress of the pathway. The TAVI has been improved technically over the past several years in terms of access. You can perform transapical, you can perform transfemoral, you can perform transcarotid, you can perform transsubclavian. The sheaths are getting smaller, and the hemostatic management post TAVI is becoming easier and easier by all the devices available for hemostasis now. The TAVI valves also, you have now the retrievable valves, the partly retrievable valves, and the fully retrievable valves. And you have all the sizes now, up to the smallest annulus sizes and up to the biggest annulus sizes. Studies are ongoing not only in that, they are ongoing in the bicuspid aortic valve. Studies are ongoing on TAVI for aortic valve regurgitation actually. So yes, TAVI is evolving very progressively and very rapidly nowadays. And it actually has been performed on the low risk and on the intermediate risk patient. And the only step is the expenses. But as we have learned, it's not only the expenses of the procedure, but it's the expenses of the total hospital stay, the repeated follow-up, the complications post-procedure, and so on. So actually the future regarding this pathway will be definitely towards intervention, and the population benefiting this intervention will be expanding more and more.
I think the years are on, even the expenses of the valve itself after the mass production and the large population that will be indicated for valve will decrease soon
Yes, yes,
as we move on with more patients, as the natural history of every innovation. Stents, the drug-eluting stents were extremely expensive, and then now it replaced completely the bare metal stents because the cost is now comparative. I think this will be the future in the next 2 or 3 years regarding the TAVI itself.
I totally agree.
So do we have any questions from the YouTube?
I think we're done. It's time for you to wrap up the session.
So we discussed today the systolic murmurs or the aortic stenosis and mitral regurg. We did show what the guidelines is saying and how to implement these guidelines to the real life or the real patients. What are the challenges that we may meet in the aortic stenosis and in the mitral regurg, and whether these are independent diseases or they contribute directly or indirectly into the condition of the patient, whether to depend upon the left ventricular function in both valves, or do we have the choice of only symptomatic treatment regarding the mitral regurg, or do we really improve the mortality of the patient in the aortic stenosis, and how to do it? We learned upon the emerging interventional treatment of both the mitral regurg regarding the mitral clip and the TAVI. The mitral clip is regarding the evolution of TAVI is less behind till now the TAVI. The TAVI is present and improve its indication a long time. So hoping that the intervention option will be more in the future to decrease the risk and to give the opportunity to more patients to benefit from this treatment. We had a lovely group of panelists with us. Thank you so much, Dr. Karim Mahmoud, Professor Hatem, Dr. Ahmed Saeed. We had an elegant, as usual, speaker, Dr. Muhammad Zahran. So thank you so much, and stay tuned to the 3 usual meetings that we do every week: the congenital at Saturday, the intervention at Tuesday, and our Thursday valvular meeting. Thank you so much to stay with you stayed with us, and goodbye.